now.
Thank you so much, everybody. It's my great pleasure to be with the Latin American community. I always wish when I have an online talk there that I would be there. So I hope next time I can be face to face there with you. So I'm going to share my screen. Can you see everything?
Yeah, it looks perfect.
Okay, perfect. So primary site reduction in epithelial ovarian cancer, how far to go? It's a topic that we all like to talk about, and it's a topic that we never, if we give 20 times this talk, it will be 20 times different answers and aspects that we have to consider. So these are my disclosures. So we know that in ovarian cancer, the debulking or so-called the site reduction is an ongoing paradigm. We know that since ages that patients who are operated without residual disease, they live longer than those with residual disease. And we know that this is the case even in higher advanced case stage patients. So a stage 4 patient who is operated tumor-free has actually a better survival than a stage 3 patient with residual disease. And this applies to any timing, primary or after neoadjuvant chemotherapy. So in ovarian cancer, we know that the better we operate, the longer our patient will live. And for that reason, we as gynae-oncology community have increased radicality, have joined efforts to increase safely radicality as a tool to improve patients' outcomes. So in the past, we used to think it's radical to do unblock resections, rectosigmoid, infrarenal lymph nodes, diaphragmatic resections, and all that is now completely normal and part of everyday job. And we now have gone even beyond that and have gone and removed pleura, parts of the paracardiac nodes, of the mediastinal lymph nodes, celiac trunk, exabdominal lymph node resections, and we keep going and going and going. And the question is, how far do we go at the end? Yeah, the ESMO-ESCO guidelines are very clear. The ESMO practical guidelines that were published a few years ago and now have been updated, and they say exactly the same. It's that complete site reduction is the way to go in a maximal effort setting. And what is very important is that this happens within a specialist training environment with surgical expertise so that the patient has the least complications and the best outcomes. So the way to go is always surgery in a centralized care in a specialist center with the adequate infrastructure and training. So there are many scenarios. Our ovarian cancer patients are many, yeah? They come through the door and we never know whether they will have a good or a bad biology, good or bad disease. And therefore we have tried within the gynae-oncology community to set limits and set algorithms of who should be operated, if surgery, at what time, before, after chemotherapy, and if surgery, then how far to go. Yeah. So ESMO and ESCO has done a very nice consensus meeting to say, to answer those questions. So what they have said is that this surgery should be done in a specialist ovarian cancer center in a multidisciplinary setting. Complete tumor resection is what should be the preferred way to go. Yeah, not after chemo, but upfront. And in patients who can be operated tumor-free, and even debulking with residual disease less than 1 centimeter, we should operate on them if it's in histologies that are not very chemo-responsive, like, for example, low-grade disease. So we have started constantly expanding the anatomical limitations of operability. Yeah, this is what happens. And this is what happens in communities in Latin America, in Europe, in the UK, in America. And we have, it's sometimes very difficult to find borders and algorithms where to go and how far to go. And I hope I can try in the next minutes to give you a framework. So in order to see how far we go, we need to first delineate what do we need to do in order to get somebody tumor-free. So for longer, we had only retrospective data for that, but now we know, according to prospective surgical high-quality studies, like the LION study, black and white, what needs to happen in order to get somebody tumor-free. So we have, we know that the primary ovarian cancer patient who has surgery upfront, in order to get her tumor-free, she will need approximately half of the patients will need a gastrointestinal resection, 1/5 will need a splenectomy, 10% will need a stoma formation, around 60% will need parts of the diaphragm stripped or cut, yeah? And of course, equivalently, we have complications that go with that. These are long operations, 10% readmission, re-laparotomy, 2% mortality, blood loss, lymphocyst, thromboembolic events. So these are tables that, for example, I personally use in my clinic to discuss with the patients when I have them as patients to prepare them for primary debulking in order to say, in order to see that they're happy to proceed, yeah? So in order to bring a bit less arbitrarity in this, and in order to try to make surgery a bit less an alchemy, but more objective, ESCO, the European Society of Gynaecology, has established a program in 2016, which I then have renewed in 2020, the Quality Assurance Indicators in Advanced Ovarian Cancer Surgery. And there we have set very clear criteria of inoperability, where we say, okay, beyond that, we shouldn't actually go. And yes, we can expand the anatomical borders, but we shouldn't push them too much in specific indications. For example, diffuse deep infiltration of the root of the small bowel mesentery, diffuse carcinosis of the small bowel involving large parts so that the patient will lead to a short bowel syndrome. I mean, I'm operating after this talk here, bowel obstruction in a patient with a chronic bowel obstruction who can't eat or drink with a transition point in a platinum-resistant time frame, who can't get chemo now because she keeps vomiting. So yeah, the risk there that she will go into short bowel syndrome is, of course, much higher. However, the question is, what is the alternative? And the alternative is that she doesn't really have a quality of life, can't really proceed. But in a primary patient, we always have the option of neoadjuvant chemotherapy, of alternative options, so that we don't render this patient for longer term on chronic TPN dependent. Then diffuse involvement or deep infiltration of the stomach, duodenum, head or middle of pancreas, involvement of celiac trunk, hepatic arteries, or left gastric artery. However, if you have a solitary lymph node on the celiac trunk, that's absolutely resectable. And of course, if you have extra-abdominal disease in terms of multi-segmental parenchymal liver mets, lung mets, non-resectable lymph nodes. I had once a patient who couldn't wear her necklace because of big lymph nodes in the neck, of course, or brain metastasis. This doesn't mean that patients with splenic mets, capsular liver mets, single operable liver metastasis should not be operated. These patients are operable, depending, of course, on their overall performance status. So what do we as gynaecology surgeons need to know from preoperative imaging in order to predict operability and say, okay, let's try this and let's try to go far? We have CTs, we have PET CTs, we have ultrasounds, we have MRIs. So we all have many imaging modalities now that everybody does with us without really any standardization. We know, and this is a very nice study that I did in a few years ago in Imperial, that the conventional CT has a high specificity and negative predictive value, yes, but has rather a low sensitivity and low positive predictor value in key areas of resection. For example, if a CT says there is no disease in the small bowel mesentery, it more often might get it wrong, especially in the case of small nodule carcinosis. So if a CT says there will be small bowel disease, probably there will be. But if it says it doesn't, there is no disease, then the probability that there will be disease is there. So how accurate is the detection and characterization of peritoneal carcinosis and implants? These are pictures that I've shared in the past to René, and perhaps he has shown them to you, but I always like to show them because they're very showing exactly what I want to say. So you see here a patient with a mesenteric carcinosis. You see that the small bowel is completely free, the small bowel serosa, but the mesentery is completely involved. And you see that we can remove it all so that you can strip the entire mesentery. The entire mesentery can be stripped as long as the border here is free, as opposed to that picture, where it's a completely inoperable case. So both patients would have in the CT, the report mesenteric carcinosis. But do the patients belong to that category or to that category? Is unclear till we unfortunately go into the abdomen. Yeah. So for that reason, and again, in order to bring a more standardization into that, ESCO, together with ISWOC and IOTA and ESCE, has done a consensus on the preoperative assessment of ovarian pathology. And what we have said is that, yes, the tumor markers can be helpful, but they won't, of course, predict the probability. But the PET-CT is not the way to go, especially in small nodule carcinosis. What is something new now is the MRI, especially the diffusion weight MR, which can characterize very well between benign, malignant, and borderline masses. However, what we also have said is that, and concluded, is that imaging alone cannot detect reliably the entire extent of peritoneal carcinosis. So imaging alone should not be used for surgical decision-making in terms of prediction of peritoneal tumor resectability. Unless, of course, you have a patient where the CT shows the whole liver is full of disease. If a CT shows mesenteric carcinosis, that's not a reason not to operate the patient, unless you open up and see whether indeed you can strip it or not. So, because very often these cases are like, I always say, like a Kinder Egg surprise egg. You open up and you never know what you will find. We need better imaging and better selection of those patients. So we have done in Imperial the MROC study. The MROC study is a study that I hope I can present to you the results next year. It's a study where we compared CT, conventional CT, with diffusion weight multiparametric MRI or combination of both to predict operability, predict timing of surgery, predict things like time to chemo, re-laparotomies, the number of surgeons needed to operate, the readmissions of the patient, delays in treatment, and even a health economic analysis, of course, within the NHS, but NHS is a very restricted system, so it will apply also to other restricted healthcare systems. And we will see whether perhaps the diffusion weight MR is the new way to go in order to better predict peritoneal carcinosis on those patients. So what I always say is that we don't really operate a tumor, do we? We don't operate an image as doctors, we operate a patient. The woman is our patient. So the question is not whether a patient is operable, or not the tumor is resectable, but whether the patient is operable. And the patient, whether she's operable, is of course in relation, yes, to the tumor dissemination status, but also to age and performance status. We have young women who are less fit than this one here, and we have older women who are never eligible for surgery. We know that there is a disproportionately high complications profile in older patients with comorbidities if you operate them up front. Yeah, so we have here, these are German data, the 3 months mortality in an upfront patient, upfront set reduction at the 75, age of 75, plus comorbidities is almost 30%. And 6 months mortality, 40%, so very high mortality. And we know that this is not because we took out the spleen or took out a part of the bowel, but because because of the volume shifts. The patients with ascites, this is a nice study from Berlin, patients with ascites and pleural effusions, they have a higher risk of ITU, volume shifts, blood transfusions, length of hospital stay, intensive care stay. So you see here that patients without ascites or with dry disease, they do much worse than wet disease. And this is, in my eyes, also one of the major pros of and benefits of neoadjuvant chemotherapy, converting wet to dry disease so that the patient can cope with the operation much better. So we did the AGO Fragile a few years ago in order to do a prospective assessment, like a crystal ball of an algorithm of fragility scores when a patient will do badly after primary debulking. Yeah. And this is a study that was presented a couple of years ago by Felix Hilpert. This was a so-called Fragile study, and what this study showed is that if you operate, it was almost 500 patients, operated up front in stage 3 and 4. Okay. Interestingly, a fourth of those patients progressed or died within 10 months from registrations, from surgery. And this is a number that also correlates with the Lion study. So you should know that in the primary debulking, approximately 1/4 of your patients will do badly and will die or progress the first year. So only 3 out of 4 patients will benefit. And the question is, who are those patients who will do badly? So what we have seen here is that it is the older patients, the patients with a poor performance status, and interestingly enough, the patients with bowel or bowel symptoms, which is probably a sign of more disseminated disease on the bowel. So these are the 3 criteria that were at the end significant in the multivariate analysis. So what we concluded there is that there are independent risk factors. Yes, of course, we need to prospectively validate it, but this is, for example, a good recipe for you to detect and select your patients. So there is no discussion that neoadjuvant chemotherapy has brought a very big change in the front of ovarian cancer, very big change. Patients who perhaps in the past were not operable now are because of neoadjuvant chemotherapy. We know that we don't make them live longer, but we reduce surgical morbidity. However, in non-expert settings, we know that there are significant limitations in that despite the fact that after neoadjuvant chemotherapy, we operate them with higher complete resection rates, these patients don't live longer. So yes, neoadjuvant chemotherapy is good to convert wet to dry disease, bring a patient who is in a very bad state upfront and can't be operated in an operable stage, or bring a patient with diffuse inoperable liver mets to an operable stage, yes. But a patient who is young, fit, healthy, with operable disease, we don't really know whether neoadjuvant chemotherapy is the way to go. Unfortunately, the studies so far, they were of very poor quality in terms of the surgery. We see here the chorus study, very short PFS, no matter in which timing. So the only thing we can conclude is that tumor residuals after neoadjuvant chemotherapy is not the same as before. All the neoadjuvant studies so far were longer time ago, recruited over a long period of years, so we can't really rely on them. And for that reason, we have done the TRUST study, which I hope I can report to you in the next end of next year. So what is the actual question about these operations? Not really when to operate, because at the end, all of us who are experts in this disease know when we shouldn't operate. A patient who is older, who has extensive disease, these patients will break them, and we shouldn't push the limits in that. The question is, what do we do with a fit patient who has extensive disease? And how do we know that by identifying the patients with high tumor load and saying, oh, this is a young fit patient who might need 2 bowel resections, might do well, but does she really benefit from that surgery? Is it not better to just give some chemo first and see how it goes? And I even bring it further. How do we know that 10 millimeters residual disease up front is worse or better or the same than operating tumor-free at interval? And how do we compare those 2 situations? So until we have the TRUST study, we won't have the answer to that. There were some very nice data presented in ESGO in a couple of years ago by Florian Heitz, by the Essen group, who showed that even if you operate a patient up front, not tumor-free, but with residual disease less than 1 centimeter, she actually will do significantly better than a patient with more than 1 centimeter. And in low grade, it's even more the gap, you see? So it does matter sometimes to operate them even upfront, even if we can't get them completely tumor-free, but just to get them less than 1 centimeter, as long as, of course, the morbidity and the impairment of the quality of life won't outweigh the benefits, the risks. And of course, at the end, the problem is that even though very often we use neoadjuvant chemotherapy as a diversion, and we all discuss in big meetings about surgery and when and how far to go, there are many patients worldwide with ovarian cancer who never ever have surgery. These are data from the UK, which is a centralized care system. So we have actually very well documentation of all patients, where we see that approximately 40% of our patients never ever receive surgery, ever. And 38% not even ever receive chemotherapy. And 30% of patients neither, not even surgery or chemotherapy. And we also know so these are UK data. And we also have the Memorial Sloan Kettering data, real life data that show that approximately a third of patients after neoadjuvant chemotherapy never receive surgery, never. Either because they die, or they go lost to follow-up, or they have comorbidities, or they don't want to, or they don't respond well. So again, neoadjuvant chemotherapy is not a panacea, but it's sometimes also a way to fail. And even though we don't really have any direct prospective comparison of is it better to operate upfront a very high tumor burden patient or divert it to neoadjuvant, we have very nice data from a study that I did a few years ago in the UK, where I compared two centers, Center A and Center B. Center A would operate almost all patients, and only the very poor prognostic, all very extensive ill patients would not get surgery. And the second center only operated approximately 60% of patients. So 40 would not have surgery. And we compared survival of these two centers as whole center. And we see that Center A had a significantly better overall survival than Center B, just by operating. So by adding the increment surgery in the recipe of management, we have a 60% improvement of the survival of this collective. Okay, so we have seen now that to push the limits is good. We have seen that we can strip mesenteries. We see that we can improve imaging in order to get the patients better qualified and better selected. And we have seen that even to get somebody less than a centimeter is good, and we just need to wait for the trust study to see what happens in the high tumor burden patient. The question is, what is the elephant in the room, and what about tumor biology? How far shall we go in patients with bad disease? Bad disease, yeah. And the question is, how can I have a crystal ball to detect those 25% of the patients where, despite great surgery, they will do badly? So I want to present you the concept of radiomics. I don't know if you have it in your countries. This is something that we have started in Europe a few years ago. This is a quantitative measurement of it's a segmentation, that's how we call it, of conventional CT images, where patients with here is the primary mass, they get segmented, and we have an RPV measured. And we have seen that patients with an RPV high will have a very bad survival, even if they get operated tumor-free, as opposed to a patient with an RPV low that will do very, very well. And we see here that the validation analysis of the novel of this RPV was quantified also in the team of Andreas Dubois. So again, there are patients with great surgery, but with a bad RPV, they had a poor PFS, regardless on how tumor-free they were operated. So artificial intelligence, it was a very big wow. When we presented this here in the UK, we had a mail online who said artificial intelligence can predict chances of survival. So even though this is like a bit of, for the lay people, it's important that we as doctors recruit novel technology like artificial intelligence to predict the outcome of our patients. And of course, I couldn't talk about borders of operability and how far to go when I wouldn't address the huge factor of infrastructure. I mean, we all here on this call come from different countries, yeah. We have seen during the pandemic how healthcare infrastructure and resources and money is important for our patients. I hadn't, during the pandemic, operated any single upfront ovarian cancer patients for 6 months because I had no beds, no money, no blood, no anything. So you can't push the limits in an operation, no matter if you are the best surgeon in the universe and can strip the best mesentery, if you don't have the infrastructure to back you up. If you don't have the financial resources, the healthcare regulations, the theater time, beds, everything, including postoperative rehabilitation. Yes, we all are getting better and increase complete resection rates. And yes, patients want to live. And patients are happy to exchange morbidity, surgical complications with years in their life. But we can't ignore the fact that we all are limited by the setting we operate. Yeah. And And of course, quality of life is one of the largest issues about this operation. I just had before this talk today, a meeting with a patient, a young woman, low-grade ovarian cancer, extensive disease, who told me, you know something, Cristina, I want quality of life. I don't want time, I want quality of life, which was very interesting to hear from a young patient. And you see here the very nice SOCA study that we just published last year in BJOG, that shows that after, no matter how terribly extensive surgery is, after approximately 6 months, you see that the quality of life is better than before the operation, and also after the operation. And it does not differ depending on whether you had a small or a big operation. So at the end, everybody will get used to a stoma, everybody will get used to a hernia, but the patients will need a few months. Yeah. So as the last part of my study, of my talk, I will present you the TRUST study. The TRUST study is a study that most of you, I think, know. It's a primary versus neoadjuvant chemotherapy study in only expert centers. The trial will have a hazard ratio of 0.75. So we hope that primary surgery will have a 25% improvement in survival in the primary setting. We hope that we could report to you by the end of this year, but the patients that were operated all in expert centers, as you see here, all fulfilling the ESCO quality assurance criteria. And for that reason, we don't have already the events we wanted to. So many of those patients are alive, despite the study having finished 5 to 6 years ago. So I think I will need approximately the end of next year so that we are able to report this to you. You see here the centers who were allowed to participate. They were excellent centers. They had availability in blood bank, in ITU. They could do specific procedures. You see here, we had to go around and check everybody whether they could operate and do either diaphragmatic stripping, bowel resections. So everybody had to show that they could do that in order to participate. You see here the recruitment status. We recruited 800 patients. We finished 5 years ago in only 2-3 years. It was a very fast study. And you see here people from all Europe and the US. Until then, what do we do? How far do we go? We have published algorithms for epithelial ovarian cancer surgery. This is a very nice algorithms from ESGO. So you have an epithelial ovarian cancer patient. The first thing you need to decide is does the center have the adequate skills and resources to do this operation? If no, then send to somebody who can. If yes, then proceed and see, is the patient in advanced stage or early stage operate, advanced stage, see whether she's fit for that extended surgery. If she's not fit, then she goes to neoadjuvant chemotherapy. If she is fit, we have to see whether it is operable or not operable, applying the selection rules that I've shown you before. And if the patient goes into neoadjuvant chemotherapy, then we have to see after 3 cycles whether she has progressive disease. If she has progressive disease, then absolutely no surgery. If she has stable disease or improvement, what we do is that we call her for interval debulking surgery. This very nicely here put in a single slide by Andreas Dubois and Ignace Fagota. There is no decision that neoadjuvant chemotherapy is one of the key improvements for ovarian cancer surgery, but it should not be used to compensate and replace skills or good quality. It should be used to very clear indications, like, for example, in an elderly patient from very wet disease, emergency surgery, fresh clots, chronic conditions that are not compliable or compatible with surgery, and of course, always patient's wish. We should never tell our patients what to do. We should offer them the risks and benefits of all approaches so that they can make an informed decision. Thank you very much.
Dr. Fotopoulou, thank you so much for an amazing lecture, as always. Primary citoreductive surgery in ovarian cancer. We had more than 90 connections. We're going to use again the QR code so our participants can answer the questions again. And while they're answering, we have some questions for you from
Yes, of
our
course.
chat and also some other questions. Just give me a second. I'm going to share the QR code and then we can keep going with the questions. Este es nuevamente el código. Por favor, todos escaneenlo y contesten las preguntas. Muchas gracias a todos quienes se conectaron. Dr. Fotopoulou, you know, even when the pleural effusion cytology is part of the FIGO staging, right now, with all the things that we do, with the option of using BATs, with the idea of using BATs to see if there is pleural disease, right now, what's the value of pleural effusion cytology in this upfront setting for decision making? Do you think is there any value, or should we abandon the use of pleural effusion cytology in all patients with moderate or severe pleural effusion should undergo BATs?
Yeah, so pleural effusion, that's why we have classified it in FIGO as 4A and not 4B. Has a different impact on survival than the 4B patients. So positive pleural cytology is not an exclusion criterion to operate. VATS is a very good way to see not if there is a carcinosis on the side of the diaphragm on the pleura, because this is completely resectable. The question is whether the patient has diffuse carcinosis in the entire pleura. Yeah. Yes, absolutely. I mean, we now have such good imaging in terms of diffusion rate MR that my radiologist usually will tell us if there is such an extensive carcinosis, in which case we step back. Otherwise, so we don't routinely do VATS. What I have, however, done is to put, when I resect the diaphragm and I see there is carcinosis, to put in a scope via the diaphragm and inspect the whole pleural cavity, yes.
Okay, we have one question from our chat that says that they would like to know what's your opinion regarding of metastatic hepatic lesions resection when there is involvement of at least 3 different segments, but with real small lesions, I suppose after chemotherapy, maybe less than 5 millimeters. They're asking if you consider for those patients the option of thermal ablation, if you consider for them a hepatectomy, or if that's possible only a metastasectomy.
You mean liver or bowel? I couldn't hear very well.
No, liver.
After neoadjuvant or before?
I suppose after, because they are talking about a real small lesions of less than 5 millimeters.
But less than 5 millimeters? I mean, okay, so if they were before the chemotherapy bigger, and then like big centimeters, and then they after neoadjuvant chemotherapy only small millimeters, then we assume that they are cancer cells and not inflammation or cysts or whatever. In which case, we have to see whether it's sensible to operate or just to continue neoadjuvant chemotherapy. Yeah.
Yeah.
That is the first. The second is if they were 5 millimeters before the neoadjuvant chemotherapy, they have completely responded. The whole abdomen has completely responded, and they have remained 5 millimeters, whether they are indeed cancerous or not. I mean, perhaps they're not. Where I see more the value of local thermal ablations, etc., is in relapse disease, where a patient, for example, with relapse solitary multifocal disease, yes, that we have the so-called oligometastatic disease, that we do CyberKnife or we do thermal ablation, yes, absolutely, so that you don't go into metastasectomy. As always, I mean, we know the value of surgery at relapse, so where I can operate, I would operate. In patients who don't want or can't be operated, then yes, we can divert to other non-surgical options. This is a very big chapter of oligometastatic disease, which we now have addressed in our new ESCO-ESMO guidelines, where we say that in oligometastatic disease, we have to see, depending on whether something is operable or not, to apply thermal ablation, CyberKnife, and local ablative techniques, yes.
Okay, great. Doctor, in some patients, when we take them to the OR and we consider that that's going to be such a big surgery for cytoreductive procedure and always think about what's going to happen with those patients later and thinking performing appendectomies, but also sometimes something like routinely cholecystectomies, you know, thinking on that.
Cholecystectomies, why?
Yeah.
Why do you want to perform
Because it's going to be a hostile abdomen later. So if we have some patients, for example, with a big upfront surgery, sometimes we routinely perform cholecystectomies. And I wanted to know what's your opinion on that?
Absolutely not. So I'm known to be a radical surgeon, but I only want to apply radicality when it's necessary. We have resected gallbladders. So we shouldn't increase radicality and increase complications if it's not necessary. The probability, I mean, if you operate somebody with a terrible, huge gallbladder full of stones, yes, you might as well remove the gallbladder during the operation. But if you operate a patient who doesn't have any problems with a gallbladder, it's a completely normal gallbladder, it's at the age of 60, why will this patient suddenly, why will you remove it? I have had terrible complications from patients after gallbladder resections in carcinosis with injury of the biliary, it's carcinosis, you try to retract, and then instead of cutting the ductus hyalodicus, you make an injury in the ductus hepaticus or biliary leaks. So not unnecessarily increase radicality unless it is necessary to do so, because also these small procedures may have complications.
Okay, do you think the same for the appendectomies?
Appendicectomies are easy. I mean, in our new guidelines, we now say we don't need to do it. I only remove the appendix if it is diseased, otherwise I don't. I mean, can you imagine, you're going to laugh probably about what I'm telling you, but can you imagine you operate an ovarian cancer patient, she does amazingly well, she lives forever, yeah? And then she gets a vaginal cancer 10 years later, and you do an excenteration, and you want to do an ileum conduit, a continent pouch, and you don't have the appendix to do that because you took it out because you just fancy to do it. Everything has a use.
Okay.
And you know that appendicitis, they're usually in children or in specific ages. How typical is that a 70-year-old will get an appendicitis?
Probably more than the vaginal cancer after the treatment.
I know. You're right. You're absolutely right. That's why I'm saying it's a game. Plus, yeah. I mean, hostile abdomen. David, I mean, we operate now patients secondary, tertiary, quaternary, we can't remove organs just because it's easy to be removed.
Great. We have another question from our chat, and the question is, how many neoadjuvant chemotherapy cycles would you consider for your patients? I suppose when there is no good response after the first 3 or 4 cycles, if you think that those patients can receive 6 or more than 6 cycles before undergoing to the OR.
That's a very good question. So the question is, why do you give neoadjuvant chemotherapy? If you give neoadjuvant chemotherapy because this patient has full liver mets, inoperable liver mets, and after 3 cycles, these inoperable liver mets are still there, then there is no meaning to operate. You have to continue. And then after 6 cycles, the liver mets are gone, you operate. Okay. If you give neoadjuvant chemotherapy because the patient just had a clot, a pulmonary embolism, then you don't need, and you just want to overbridge the time of anticoagulation, then you don't need more than 3 cycles. So 3 cycles. So all the studies we have in neoadjuvant chemotherapy are for 3 cycles. We know the old Bristol data that above 3 cycles, the longer you wait to operate, the worse the survival will be. But this might be because perhaps it was biased data. Therefore, there is currently a French study, the Chronos study. It's a study that compares 3 versus 6 cycles for neoadjuvant chemotherapy, whether there is a difference. I mean, I have operated in the pandemic even after 8 cycles of chemo. And the majority of my patients after 8 cycles of chemo had no cancer. I just did a hysterectomy. So you can even, you push it, and the question is, do I need to operate? So these are questions that, I mean, we don't want at the end to do a blind surgery. We want to see what we're operating.
Oh, great. Great. But there's another related question to that. When you use 6 or more cycles of neoadjuvant chemotherapy, you always use adjuvant chemotherapy after the surgery. You know, there are some centers that consider that treatment is only those 6 or 8 cycles. We consider that patients should receive those.
That's a very good question. So if I operate after 6 cycles and the patient belongs to the very few small percentage of patients who have a complete pathologic response, so no cancer, nothing, all specimens negative, then I stop. I don't give chemotherapy.
Okay.
If, however, the patient will have active tumor, then we will consolidate with 2 cycles after the operation.
Okay, great. There's another question from the chat, and it's regarding if you think after the TRUST study results, and of course with the current evidence that we have regarding targeted therapies, and I suppose particularly with PARP inhibitors, should we insist on research in HIPEC treatments? And I think we also want to know from another question if you are participating in a HIPEC trial or in any other HIPEC trial in the center.
Yeah, so I will start with the second question. I started wanting to recruit in the Van Driel primary study. I don't remember the name anymore, the primary HIPEC study. Yeah. And then COVID came, and then I had nowhere to operate, so I stopped, and then I lost the will, and then I haven't restarted. The problem with HIPEC in my center is that we have a big HIPEC machine, which is in the other hospital, not in my hospital, even though it's one center. So it is a bit logistically difficult to make it, and I just haven't done it yet. So, but theoretically, I would, yes, like to do it because it's always good to answer questions. So we know from studies and meta-analysis and whatever, and I have also made with the Koreans and with Van Driel, with Wilhelmina, very nice meta-analysis in gynecology we have published last year. HIPEC has no benefit in patients who are chemo-naive. So patients who had chemo in the last 6 months before surgery, HIPEC is better than no HIPEC. But if they're chemo-naive, either never had chemo or had chemo longer than 6 months, then HIPEC does not add benefit. So if the TRUST study shows that primary surgery is better, then HIPEC is out of the question unless you operate at neoadjuvant chemotherapy. And then you need to see why this patient had neoadjuvant chemotherapy, if she's ill and is multimorbid and old, whether she will, she can cope with HIPEC, or whether just do a simple hysterectomy and leave. If the TRUST study is negative and the neoadjuvant chemotherapy it won't be better, it will be eco-efficient with less complications. Yeah, that's what I think. If it happens, will happen. Then we have to, what do we do then? Yeah, so we have to do a study, theoretically. We have to do a study theoretically of interval debulking and HIPEC versus primary surgery without HIPEC.
It's going to be tricky. Dr. Fotopoulou, while most guidelines recommend only an infracollic omentectomy as part of the surgical stage.
Oh, nobody, which guidelines? No, not my guidelines.
But actually, yeah, the recommendations from FIGO just says that only an infracollic omentectomy, it's enough for patients with ovarian cancer. We usually in clinical practice perform supracollic omentectomies for all our patients.
Infragastric omentectomy, yeah, supra, not infracollic.
Yeah, supracollic, yeah. But
sorry, I heard infracollic. Sorry, yeah.
No, but actually the guideline has said for a long time that on infracollic omentectomy is enough for patients with ovarian cancer.
That's not, I don't know which guidelines say that.
The FIGO guideline for surgical staging, but they don't recommend supracollic.
For staging, it's different. Staging is if you have a stage 1A.
No, exactly. It's for staging, not thinking on patients with momentum disease. We all, I think, agree that if there is disease in the momentum, a complete omentectomy should be performed. But for those patients in the surgical staging of with ovarian cancer, we typically perform a supracollic omentectomy. I just wanted to know what's your opinion on your practice for those patients undergoing surgical staging for ovarian cancer.
Okay, so when we talk about staging of ovarian cancer, we mean that we remove normal omentum for patients with presumed stage 1 disease, correct?
Yeah.
So we remove the omentum, not for debulking. So when I operate, let's say, an advanced ovarian cancer patient with diaphragmatic disease and with lymph nodes or whatever, and she has disease only in the infracoiloid omentum, I, despite of that, will also remove the supracoiloid omentum. So I will remove also the supracoiloid omentum if the supracoiloid omentum is normal, okay? In an early stage, presumed early stage ovarian cancer patient, then do you really want to tell me you go till the splenic hilum like you do in an advanced ovarian cancer patient? Nobody does. Nobody does. You will never go till, you know, in an advanced ovarian cancer patient, I will remove the omentum till the splenic hilum. I will shave the spleen. I'm not going to do that in a presumed small ovarian tumor. I'm not. So yes, I will do a supracoiloid omentectomy, but not as radical as in an advanced ovarian cancer patient. That is my answer.
I think it's the same for us. There's another question from the chat that said that you have talked about predicting surgery success with CT scans and all the tools that you have there. But the question is how to train a radiologist.
Yeah, that's a very good point. Very good point. So very good point. So like we need to be trained, in operating. The same is our pathologists need to be trained in seeing the pathology reviews and our radiologists to see the images. So we can't have specialization of gynecology surgeons and not specialization of the team. So like you and I need to be trained and come to meetings like today and go to cadaver courses. The same needs to happen with the radiologists. But for that reason, we need to have national badging and certification of gyne-oncology radiologists, gyneco-radiologists. So in the UK, we have gyneco-radiologists. So we have radiologists who will see brains the whole day, or who will see bones the whole day, or will see gyne cancers the whole day. Yeah, if you have a country that demands from one radiologist to know brain, as well as legs, as well as bones, as leg, it's impossible. I mean, it's impossible. Then we have to restructure the whole country.
Okay. Regarding the peritonectomies, do you selectively perform the peritonectomy only where the lesions are located? In this upfront setting, you know, it's kind of tricky at the interval setting with some scars and all this thing. But in this setting, do you apply any margin for the lesion that you're removing when there's a small one, or you prefer to remove the entire peritoneal zone?
Yeah, okay. So if it's a primary surgery, because in primary surgery is you see what you get, what you see. That's why HIPAC doesn't have a meaning probably, because you see everything. I will remove only what I see. If now the whole, for example, the whole diaphragm has one small lesion, I won't strip the whole diaphragm. No, I will only remove the small lesion. If now the diaphragm has a small lesion there, a small lesion there, and small lesion there, a small lesion there, then yes, I will remove the whole diaphragm. Yeah, I won't start making holes. So I will remove the compartments. The same with the lymph nodes. If it's a single bulky node, I'm not going to only try to dig to remove this one bulky node. I will remove the whole compartment of the lymph node. Okay. In neoadjuvant chemotherapy, it's tricky. Because in neoadjuvant chemotherapy, I think that is why the neoadjuvant chemotherapy patients, they don't live longer, even though we say we operate them tumor-free. I think it's because we actually don't operate them tumor-free, because we think it's a scar tissue and we leave it in and we don't take it out. Yeah. So I'm not going to strip the whole diaphragm just because of a scar. I'm not. If there is disease, I will do it, but otherwise I won't. Because I want to switch the question and ask you, yes, to strip a diaphragm is easy, but would you do a rectal resection in an adjuvant patient because of a small scar? You wouldn't.
Yeah. Right.
So why to strip the diaphragm when you wouldn't do the rectum? It's inconsequent. Either you do everything or nothing. You know?
I agree. I completely agree. You know, there are some for now maybe small studies regarding the use of image guidance to assess patients after you complete your cytoreductive surgery. Say, okay, there is no macroscopic disease using paphlocyanine or this new thing, pegcistacyanine, and all those studies show that almost 50% of patients had residual disease based on the image, and almost something like, I don't remember, 60 or 70% of those patients at the end in the pathology report or actually had disease. So you are losing something like 30% of disease using those image guide tools. What are your thoughts on that? Do you think are we going to use them in near future, or there is no value?
Intraoperative, I'll keep forgetting the name, where you put into the abdomen the folate receptor.
Yeah.
Okay.
What do you think it's the value of using those technologies?
Okay. So we have to differentiate between primary and interval setting. In interval setting, we as surgeons cannot see the whole disease. And again, that is why we say we operate tumor-free, but our patients don't live longer. Even though we have higher complete resection rates, our patients don't live longer. So we need better visualization of what we see in order to say we operated tumor-free. So in ovarian cancer, we know that the LION study, the lymph node study, has shown that even though we remove microscopically involved lymph nodes, 50% of the patients had microscopically involved lymph nodes, and we resected them. The patients did not have had exactly the same survival. Okay. So in ovarian cancer, microscopic disease doesn't matter, because if it mattered, we shouldn't operate any of them because all our patients have microscopic disease. You can't strip the entire cirrhosis of the small bowel. You can't strip the entire pleura. You can't. That is why these patients need chemotherapy. And all our studies about the evidence of value of surgery in ovarian cancer is about macroscopic disease. If now you start seeing everything, okay, I see a bit of disease in the mesentery. So what happens with the circulating tumor cells? What happens with the disease in the mediastinum? What happens there?
Yeah, that's completely right. This is for the chemotherapy and the PARP inhibitors, not for us. Dr. Fotopoulou, regarding the pericardiophrenic nodes in the upfront setting, which cutoff do you use for them? The same 10 millimeters? Do you have a different protocol for assessing them? And also particularly, and I don't know, it's another scenario, but we've seen from other centers that they consider after neoadjuvant chemotherapy only 5 millimeters or larger in the short axis to consider pericardiophrenic nodes as abnormal and remove them.
Okay. So I remove bulky disease if it is bulky. So I'm not going, if it is a bulky disease, definitely I'm going to remove the cardiophrenic nodes. So what I do is I follow the advice of Rob Bristow, who tells me if you can palpate the node, take it out in the paracardiac area. You can usually palpate it from below the diaphragm. If it's a microscopically involved lymph node, going back to the LION study, there is no meaning resecting it unless you want to practice and have fun. That's a different point. But otherwise, there is absolutely no benefit in removing them if they have microscopic disease. We know that. There is no reason why to remove a paracardiac microscopic, a para-aortic microscopic node doesn't have any benefit, and to remove a pericardiac has. Nobody ever, any ovarian cancer patient died of a pericardiac lymph node. No? They all die from something else.
Great. We have, I think, the last question from our chat, and it says, what's the value for you of laparoscopic surgery for planning? If there's going to be an upfront cytoreductive surgery, and if you use any score to assess resectability, if you use PCI for those patients, or if you use the Fagotti score,
I don't use the Fagotti score, and I don't use the PCI score. I don't use it. I was never trained to use it. We have, we use for the trust study the Sugar Baker score, the PCI, just for the, but I mean, I don't do routinely laparoscopy. We do a laparotomy and open up and try to remove as much as we can upfront.
Great. And I think this another question is if you consider something like if a pulmonary embolism is an absolute contraindication for upfront cytoreductive surgery.
So I have done a very old study 1,000 years ago and published it in GCO, and have seen and have showed that one of the major mortalities and poor survival of patients after surgery is pulmonary embolism. So I have a very big respect for pulmonary embolism. I would not operate after pulmonary embolism. No, I wouldn't. I would give neoadjuvant chemotherapy, wait for 3 months, and then in order to bridge. But if I have a patient with a solitary mass who can't have neoadjuvant chemotherapy and has a clot, then I will wait for 6 weeks because I want 6 weeks is very dangerous to stop anticoagulation and operate. I would wait for 6 weeks, 4 to 6 weeks, we say, and where it is safe to reduce anticoagulation. So the first milestone safe to reduce anticoagulation is after 6 weeks, and the best is after 3 months. So if it's a solitary tumor, the patient had it there for months anyway, so it doesn't harm to wait a few more weeks, whereas I can kill her by stopping the anticoagulation. I will wait for 6 weeks, and then I will reduce the anticoagulation and operate on her. Yes, because there is no option. IVC filters are not part of routine anymore. No, we used to put them, we don't put them anymore. They have shown that they can do actually more harm.
Yeah, great. Thank you. So, Dr. Fotopoulou, thank you once more for your invaluable time and exceptional lecture that you delivered. We look forward to welcome you back to Colombia soon. And have a great day, Doa.
It's my pleasure. Thank you so much for having me. Thank you so much. Hope to see you all again soon. Thank